Just getting the things interoperable didn't really solve the issue. A vendor would say, well, I can share data, but I don't want to share data with this company. Hospitals say that I want my equipment to be interoperable, but I have this legacy issue. They're all conflicted. So on one hand, they want to interoperate, and the vendors were remarkably supportive. On the other hand, it is a complex ecosystem. What is lacking is really a system for trust. You realize pretty quickly it's not just the technology. It's the clinical use of the technology. It's the underlying contracts. There are 6,000 hospitals in the country and there are 6,000 different ways of doing things.
I think we were able to accelerate some of the adoption in this last couple of years because of probably more regulatory and policy changes than anything. To his point, I don't think a lot of the technology is new. I don't think we had a shortage of data before. I don't think it was even the capacity to utilize the tech that was out there. I think it was just breaking down some false barriers that's been put up as we've grown as an ecosystem, and we had to work over them, through them, around them to get the work done. I think having a national strategy is a really important place to start.
You're also talking to the most skeptical audience in the world, right? Physicians, payers, health systems. No, the skepticism comes from the training. Most of them are scientists and doctors, and that is actually how you are trained, to question everything and to ask for the data. Nobody disagrees that healthcare needs a digital transformation. The problem is how we do that. And the problem that they tell me is there is so much digital health being thrown at employers, health systems, and payers. There's almost saturation. And there is no place that any of us can go to figure out what is good and evidence-based in digital health.
How do we go about creating an environment where we can start to create that evidence-based insights, if you will?
Digital health companies, the best ones, have clinicians at the table, and they bring them in early and they engage them often throughout the process.
Things that I personally always look for on the team are solutions that are rooted in, again, a real problem and evidence-based. It's sort of a catch-22 with our early stage companies because they often don't have the pilot partners yet, or enough pilot partners or a sample size, large enough to fully prove efficacy of product. There is a lot of just barriers to the change management side of things. I know that, burnout is a huge issue right now. So I think there's this also hesitancy of having to deal with training and further cleaning procedures and further introducing new things when people are kind of trying to stay afloat. So I think these solutions actually have the power and the ability to democratize care and reduce a lot of burdens, but based on still the fragmented ways systems are set up and the absolute burnout and retention issues folks are dealing with, it's a really challenging time to introduce what still feel like novel concepts.
In general, physicians don't really have a boss in the way that other people think, right? So we have chairmen, but they don't actually tell you how to practice on the day-to-day level, right? We all have to keep within our standard of care, and we learn our standard of care in our medical education, which has not changed very drastically for decades. And so when you're trying to introduce something new, you do have to show not only the efficacy that you're saying that you have the data, but then also you really have to do a lot to convince physicians that it's going to be safe and to the quality and standard of care. What has worked and generally does work is forcing physicians to do it. When we wanted to roll out our telehealth program within our department, we were just Jefferson, we do telehealth. This is who we are. And so physicians who work there would do it. And the fact that various bodies have now within the medical education bodies have said, hey, telehealth and digital health are going to be big topics. Telehealth specifically has now core competencies that have to be taught in medical schools. That's huge.
The payers don't want to pay for something until they can see the ROI and physician adoption. And then the physicians don't want to adopt it if it's not going to be paid for and they don't know how to reimburse for it.
One thing for sure is that the COVID pandemic has greatly accelerated the rate of innovation in healthcare. And we've had some of our CEOs, our board is made up of CEOs of hospitals and health systems. And they've said that in 1 month, they've achieved more than they've achieved in years in the past, just out of necessity. And in the conversation, it's interesting here. We talk a lot about trust at the center, and then finally, sometimes the trump card is the regulatory and the policy implications. The regulation is the only hammer that seems to be able to break through the other 5 barriers.
So I was interviewing Dr. Shantanu Nandi, and he said to me, medicine moves at the speed of trust. And that stuck with me so deeply, because that sentiment echoes across every single part of healthcare.
What I think needs to be brought out, a platform brought to the industry with the right governance models so that it can be trusted. Because when a proprietary company tries to solve it and they come out with their platform, which is what happens, it inherently is not trustable.
In the last couple of years, we have seen how the rest of this industry really has not kept up with the innovation and how fast it's been going. So this is a time to really get the other partners up into the level of the innovating. Innovating is going to happen regardless. So how do we get everyone else to catch up?
Policy ultimately drives the incentives for change. And like if policy isn't making kind of the common sense or the healthier choice, the easy choice, then people are just not going to be able to do it.
The healthcare system, everybody keeps saying it's broken. It's not broken. It's actually doing exactly what it was designed to do. We need to rethink how we do healthcare. If I was to say who is the single source, I would actually say it's the payers. Like how something gets paid for drives how it gets adopted. There's an interplay between payers and employers that can really drive change.